Kanski lecture series. This is going to be the chapter 11 glaucoma part 7, and in this part we are going to discuss about the primary angle closure glaucoma. So basically the primary means that there is no other ocular and non-ocular pathology, and it is related to the angle of the eye. If it is closed, it is causing glaucoma. Why? Because the angles need to be open for the drainage of the aqueous fluid. So when it is narrow or blocked, it will not allow the aqueous fluid to be drained, so that will cause the intraocular pressure to be raised, and that is how primary angle closure glaucoma occur. Introduction overview. The term angle closure refers to the occlusion of the trabecular meshwork by peripheral iris iridotrabecular contact, obstructing aqueous outflow. Angle closure can be primary when it occurs in an anatomically predisposed eye, or secondary to any other ocular or systemic factor. So basically the primary is depending on that there is no other ocular and systemic factors, but in the case of secondary there is an ocular or systemic factor which is causing the closure of the angle. Primary angle closure glaucoma may be responsible for up to half of all the cases of glaucoma globally and is particularly common in Asia. It progresses rapidly and is more likely to result in the visual loss than a poke. So it is more common in Asian. Gonioscopy, see chapter 1, grading of the angle width. In practice, the angle is graded by many practitioners simply according to the number of structure visible. Together with the qualifying comments relating to the width of iris approach, the angle is usually narrowest superiorly. The main aim are to evaluate the functional status of the angle, the degree of closure, and the risk of future closure. So basically, you know that the angle has four structures that are usually visible on a gonioscopy, and based on that visibility of the structure, we label it as a narrow angle or closed angle. And the narrow is slightly narrow at the superior part naturally, and so that is how the angles are graded. So there are certain systems like Schaeffer systems, Space systems, key systems. The Schaeffer system record the angle in degrees between the two imaginary tangential line to the inner surface of the trabeculum and the interior surface of the iris, about one third of the distance from its periphery. The system assign a numerical grade to each um, quadrant of the angle. So basically what you do is basically you make a tangential line. The tangential line is at the inner surface of the trabeculum and the um, interior surface of the iris. So how much angle is visible depend on that tangential line. So if only um, this much of the structures are visible, you can grade it 45 degree. If narrow angle are visible like this, you can see that here they have drawn a line. So this is a line, this is a grade 4. They have drawn the line interiorly, and you can see that here is an interior surface of the iris, and you can see the trabecular, the angle visible are about 45 degree. In grade 3 it is about 25 to 35 degree. In grade 2 it is very narrow, about 20 degree, and in grade 1 it is about 10 degree, and in grade 0 there are no angle visible and there is an iridocorneal contact. So grade 4 is 35 to 45 degrees, the widest angle characteristic of myopia and pseudophakia. The ciliary body can be visualized without tilting the lens. So first we need to understand how much structures are usually visible in an angle. First of all, we see the Schwalbe's line, then we see the trabecular meshwork, then we see the scleral spur, and then we see the ciliary body. In grade 4 open angle, basically all of these structures are visible. In grade 3 um, only 3 of the structures are visible. In grade 2 2 of the structures are visible, and in grade 1 only 1 is visible, where in grade 0 there is no structure visible. So it is the widest angle characteristic of myopia and pseudophakia. The ciliary body can be visualized without tilting the lens. Grade 3 25 to 35 degrees, an open angle in which the scleral spur is visible. Grade 2 is an angle in which the trabeculum but not the skull can be seen. Grade 1 is very narrow angle in which the only the Schwalbe line and perhaps the top of the trabeculum can be identified. Slit angle in which there is no obvious iridocorneal contact but no angle structure can be identified. Grade 0 is closed due to iridocorneal contact. Indentation will distinguish appositional from the cynical angle closure. So what is the between the appositional and synechial? Synechies are basically the adhesions that are being formed between the iris and the cornea. So what happens is in a case of apposition, when there is just a contact of the cornea, trabecular meshwork to the cornea, when you indent the angle, it will slightly open up. But in case of a cynical angle closure, even if without indentation, because there is adhesions that are formed, there will be no opening. The spade system is detailed but underused. It follows the formal description of the position of the iris insertion, the angular approach, and the peripheral iris curve. So these are not much of the use, and it has different grading system. Angular approach, position of the iris, and the peripheral iris curvature. Next is classification. It refers to the angle structure visible and allocates a Roman numerical accordingly in contrast to the common clinical use. In the original system, the higher numerical value 4 actually signifies the narrow angle. Basically, we give the 4 angle to open, but in case of a ski, in the older classification system, the 4 is considered closed angle. So it has a same system that 4 structures are visible, it is grade 4. If 3 structures are visible, grade 3. If 2 structures are visible, grade 1 and grade 2. And if 1 structure is visible, grade 1. Next is the von Harrach method. So von Harrach method is basically used to assess the AC depth. So how much is the AC, shallow or narrow, or what is the significance? A thin uses the slit lamp alone to estimate the AC angle width, and basically the depth of the AC will tell you that either the angle is closed or narrow or open. A thin but bright slit lamp is set approximately perpendicular to the corneal surface, offset from the optic by 60 degrees to the patient temporal side for each eye. The beam is used to estimate the ratio of the corneal thickness to the most peripheral part of the AC. It is useful as screening tool but or overestimate angle width in proportion to patient, particularly those with the plateau iris configuration. Evaluation of the filtration angle using gonioscopy is the key to diagnosis and treatment of the primary angle closure glaucoma. So basically what is we do in a slit lamp, because this is a cornea, what we do is we for example, this is a cornea, we make the slit on the temporal side of the cornea by making the illumination beam at the 60 degree and observing system at our side eye at 0 degree. So we make a slit, and then there is another shadow that is formed on the iris. So we just measure that depth with that of the cornea, and if it is equal to, or if the depth is equal to the corneal slit, it means that angle is AC depth is normal and angle is going to be open. So this is it. Anterior chamber depth, von Harrach method, and anterior chamber angle assessment. If the peripheral iris space equals to the full corneal thickness or larger, then it is grade 4 and it is wide open. If it is 1/2, a fourth to 1/2 space between 1/4 to 1/2 of the corneal thickness, 3 incapable of closure. If it is equal to 1/4 space equal to 1/4 corneal thickness, grade 2 should undergo gonioscopy. If it is less than 1/4 space less than 1/4 corneal thickness, one gonioscopy will usually demonstrate a dangerously narrow angle. So if you can say this is a slit beam and you see there is an iris, and you compare it with the AC depth, if it is equal to 1, it is going to be grade 4. If it is equal to, if the AC depth is almost 1/4 to 1/2, it is going to be grade 3. If it is going to be less than 1/4, if it is going to be 1/4, then it is grade 2. And If it is less than one fourth, it is grade 1. So basically, one fourth is the number that you should remember. Classification. As the knowledge about the epidemiology and mechanism of angle closure has increased, classification has moved away from the symptom based approach, acute, subacute, and chronic, to reflect the stage is in the natural history of the disease. The scheme below has been suggested by the consensus group of Association of the International Glaucoma Society. So basically, you divided on the basis of the presentation. Primary angle closure suspect. So there is going to be primary angle closure suspect, and there is going to be primary angle closure, and there is going to be primary angle closure glaucoma. Basically, the difference between them is in the primary angle closure suspect, you will see the angle narrowing on gonioscopy. In a case of primary angle closure, only IOP will be high. There will be narrow angle plus high IOP. In case of the primary angle closure glaucoma, there will be narrow angle, raised IOP, and there will be the glaucomatous optic neuropathy. So basically, primary angle closure suspect, axial anterior chamber depth is less than normal because of the convexity of the iris lens diaphragm. A crescentic shadow forms over the nasal iris when the light is projected across the anterior chamber from the temporal side. That is the eclipse sign. So this is eclipse sign that is basically measured when you in a case of a narrow angle. So it is showing is showing the shallow anterior chamber and a convex shape iris lens diaphragm. So you can see that there is a very narrow angle and the iris lens diaphragm is like this, and this is showing the eclipse sign. So in the eclipse sign, basically you put the light on the temporal side of the eye and you see the formation of the crescent. If there is a crescent formation, then you can see that there is a, and the light does not pass and there is a shadowing and crescent formation, then you can say that it is a narrow angle. Conioscopy show posterior network IATC in 3 or more quadrant but no peripheral anterior synecdoche. A lower threshold for diagnosis is used if the gonioscopy reveals true quadrants of ITC and the signs of the intermittent closure like pigment smudging. So, in a case of primary ungual closure suspect, you will see iridotrabecular contact in 3 or more quadrant, but there will be no pass. Posterior anterior synecdoche mean that on indentation the angle is going to open. Normal IOP, optic disc, and visual field. So I told you that it is only the gonioscopy will reveal the narrow or closed angle. Normal IOP, optic disc will be normal and visual field will be normal. There will be no peripheral anterior synecdoche. Anterior segment OCG shows an includable angle. The risk of developing angle closure disease in an individual classified as PAS suspect is low. The SAP study, a large community-based randomized control trial, shows an incidence of 8 per 1000 eye years in untreated PACs versus 4.2 per 1000 eye years in those who undergo laser PI. So basically, SAP trial is a study that is done in a case of a primary angle closure suspect. So what did we do is basically the one group was left untreated and one was treated with the laser peripheral iridotomy. So what happens in the untreated eye, that 8 out of 1000 eyes were having glaucoma, whereas in case of treated treated with laser PI, 4.2 out of 1000 eyes were having a glaucoma. So it made not much of a difference. So this is showing on a gonioscopy. C is showing gonioscopy, Schwalbe line and a pond of non-pigmented trabecular meshwork are visible. So you can see that here is a Schwalbe's line and this is a pigmented trabecular meshwork. And D is showing a very narrow occludable angle on dark room anterior segment OCT. So very narrow angle. Then there is a primary angle closure. Glaucoma show three or more quadrant of ITC associated with raised IOP or PAS, best evaluated using indentation gonioscopy. So I told you that in this case the IOP will be raised or PAS will be formed. Normal optic disc and field. So optic disc and field will visual fields will be normal. Some authorities further classify primary angle closure into non-ischemic and ischemic, the latter showing anterior segment evidence of a prior substantial IOP elevation such as iris changes or glaucoma flaccens. So some have divided the pack into already like ischemic and non-ischemic. Ischemic having already the signs of the prior IOP elevation or glaucoma flaccens in the lens. So basically, glaucoma flaccens are the lens infarct that are present like a white spots on the lens capsule. Um, Primary angle closure glaucoma, ATC in three or more quadrant associated with glaucomatous optic neuropathy, optic nerve damage from an episode of a severe IOP elevation such as acute angle closure may not appear as a typical glaucomatous cupping. So in this case, the glaucomatous optic neuropathy will be present in a primary angle closure glaucoma. So what are the mechanism of having a glaucoma in an angle closure? The mechanism involved in angle closure can be characterized according to the anatomical level anterior to posterior at which the causative factors act. In many patients, more than one level is contributory. So there is a relative pupillary block, there is a non-pupillary block, lens-induced retrolenticular combined mechanism, reduce aqueous outflow. So these are all the mechanism that will be contributory. So what is the relative pupillary block? Failure of the physiological aqueous flow through the pupil lead to the preferential difference between the anterior and posterior chamber with resultant anterior bowing of the iris. Usually anatomically relieved by peripheral iridotomy, which equalize anterior or posterior chamber pressure, reduction of IOP will follow provided the angles are opened adequately. This may not occur if there is a substantial peripheral anterior synecdoche or an additional mechanism of angle closure is in effect. Trabecular meshwork damage can prevent normalization of a IOP even with an anatomically open angle. The lens vault quantifies the portion of the lens located anterior to the anterior chamber angle. A common definition is the distance between the anterior pole of the lens and a horizontal line joining the scleral spur at the anterior at diametrically opposite location. Uh, a large lens vault is independently associated with angle closure, though it is not clear whether there is an entirely via pupillary block or a non-pupillary block mechanism. So what is a relative pupillary block? So basically, you know that this is a cornea, this is iris, this is cornea, this is iris, and this is lens. So you know that aqueous flow from the posterior chamber to the anterior chamber. So sometimes that there is certain conditions that are physiological that aqueous is not flowing from the posterior to the anterior chamber. So what will happen is that the aqueous will likely to accumulate in the posterior chamber, and it will causes the bowing of the pressure in the posterior chamber will cause the bowing of the interior of the iris to the anterior side. So it will close the uh, angle and it will block the pupil as well. So it is how the pupillary block mechanism come into effective. The pupil will like this and lens will be like this, and there will be the anterior bowing. And then there is a how will you treat it? So when you treat it, basically there is an anterior bowing. So when you just put the make a hole in the anterior bowing, the posterior side aqueous flow will start going to from the posterior chamber into the interior, and the angle the pressure will be normalized. And there is a lens vault. A lens vault is basically the portion of the, so you know the lens is lying here, there is an iris and there is a cornea. So sometimes the lens vault is bigger. Like how would you measure is basically you just take a distance between the interior pole of the lens, and you just make a distance between the scleral spur that is joining the two side. If this is narrow, it means that there is a large vault. Non-pupillary block, thought to be important in many Asian patients, associated with a deeper AC than found in those with a pure pupillary block. Patient with the non-pupillary block, particularly those with plateau iris, tends to be younger than those with a pure pupillary block. An element of the pupillary block is invariably present, but angle closure is not fully relieved by iridotomy. The term mixed mechanism has been suggested to describe the glaucoma in which the both significant pupillary block and a non-pupillary block mechanism coexist. So basically, the writer is trying to say is, in this case, the angle is basically the AC depth is usually uh, deep. Deep means there is a significant distance between the cornea and the iris, but the angles are usually closed. So what is the mechanism that is causing the angle closure? Is basically the iris configuration. So the iris is basically having a configuration like a plateau iris. It have a like a it is no, it you know that iris is going to be like this, straight, almost straight. So in a case of a plateau iris, it will be like this shape. It will have anterior bowing, then deep and deep at the pupillary side. Specific anatomical causative factors include plateau iris, secondary to anteriorly positioned or rotated ciliary processes, and a thicker or more anteriorly positioned iris. The concept of a thick peripheral iris roll has been introduced by some authorities. A thick peripheral iris may be relatively important in Asians. So basically, in a case of a non-pupillary block mechanism, is basically the iris is having a problem that it is closing the angle itself. So what can happen, because the ciliary body that is present on the ciliary side is anteriorly rotated. So what is happening? It is causing the angle closure. Similarly, there is a whenever there is a pupillary dilatation in a dark environment, there will be the thick iris will become very thick at the corners, at the angles. So that is why the angle get to be closed. So you can see figure 13.35 is showing the primary angle closure on indentation gonioscopy. A diagrammatic representation in a narrow angle showing inferior pass. So what is showing that it is indentation is basically you are just in making a cornea inside, and what is it, you are pushing the cornea inside, and it will allow the angle to be opened, but it will not open in a case of a peripheral anterior synecdoche. So this is a mechanism of angle closure. A is showing a relative pupillary block. So you know that the anterior bowing, basically there is the iris is the aqueous is not flowing from the posterior to anterior chamber, so it will cause the anterior bowing of the iris, and it will be relieved by, and it is causing the angle closure. And it is 11.35 is showing the plateau iris configuration. A is showing high resolution ultrasound showing anteriorly rotated ciliary processes and slit like. So this is just a slit like angles, and there is anteriorly rotated ciliary body. B is showing gonioscopic appearance showing chronic angle closure, white. So this is a sometimes border between the closed, and this is open angle. So this is some open angle, and this is a closed, and there is an iridotropicular contact. Next is a plateau iris configuration. So I told you earlier, basically the iris is itself like anatomically made that its configuration is not normal. Is characterized by a flat or only slightly convex central iris plane, often in association with normal or only slightly shallow central anterior chamber depth. So in the plateau iris configuration, the central anterior chamber depth will be normal or only slightly shallow, but the angle will be closed because of the iris configuration. The angle recess is typically very narrow with the sharp backward iris in angulation over anteriorly positioned or oriented ciliary processes. A characteristic double hump sign is seen on indentation gonioscopy. A central hump being due to underlying central lens supporting the iris, and the peripheral hump resulting from the underlying ciliary processes. So why the double hump sign is produced? Because this is a lens line, and the iris over it will have some kind of a convex shape, then it will become deep, and then its configuration is like S shape on the so this is cornea. So on the lens it will be having a slightly upper side, then in the center they will become deep, and then on the angle side it become closed. So this is how, and this will make a double hump sign. So what is a plateau iris syndrome? Basically, if the plateau iris syndrome is the like plateau iris configuration, but it is just a diagnostic term. Basically, when you are there is a narrow or angle closed, and you do the laser peripheral iridotomy, and the angle does not open with the laser peripheral iridotomy, and there is a plateau iris configuration, then you label it as a plateau iris syndrome. The plateau iris syndrome describes the persistence of the gonioscopically angled closure despite a patent iridotomy in a patient with morphological plateau iris. Factors such as dark environment or for morphological pupillary dilatation may be necessary to demonstrate the angle closure. It is divided into complete form, in which the inclusion of the functional trabecular meshwork is present, and the IOP is elevated, and incomplete form with occlusion to the lesser extent, and a normal IOP. Lens induced angle closure, an angle closure that is predominantly lens induced or is due to retrolenticular causes, is often characterized as secondary. This includes those cases in which the sudden changes in the lens volume or position leads to an acute or subacute IOP rise. Usually, rapid progression of the lens intumescence, phacomorphic or interior subluxation. All cases of the pupillary block have a phacomorphic element that increases with age as the lens thickens. So basically, lens induced mean that the lens is blocking the is so much volumetous that the pupil are the pupil iris is getting in close approximation with it. So what happen is, basically the iris will not the aqueous will not flow from the posterior to anterior chamber. So that is why it will cause the increase in IOP. Retrolenticular cause is malignant glaucoma, ciliolenticular block, posterior segment causes of the secondary angle closure. So these are the angle closure that is basically secondary type. Combined mechanism has as a formal label for combination of angle closure and open angle element. We will discuss the malignant glaucoma and other causes in the next topics. Reduced aqueous outflow in the angle closure has been postulated to be caused by the following mechanism in varying degree. Oppositional obstruction by the iris. So, how the aqueous is not flowing from the closed angle. One thing is basically there is angles are opposed, and there is no place to the outflow of the aqueous. Degeneration of the trabecular meshwork itself due to chronic or intermittent contact with the iris, or a damage sustained due to elevated IOP. So there will be also be the degeneration of the trabecular meshwork that will causing the decreased outflow. There is a permanent occlusion of the trabecular meshwork by the peripheral anterior synecdoche. The prognosis for the IOP control correlates with the extent of the peripheral anterior synecdoche. So what are the risk factors for the angle closure glaucoma? It is basically age. The average age of the relative pupillary block is about 62 years at presentation. Non-pupillary block forms of primary angle closure tends to occur at a younger age. So pupillary block will have a 62 years age, and non-pupillary block will have younger age. Females are more commonly affected than males. Race particularly prevalent in far eastern or Indian nations. We repeated it so many times that it is more common in Asians, where non-pupillary block is relatively more significant. Family history genetic factors are important but poorly defined, with an increased prevalence of angle closure in the family members. Refraction eyes with pure pupillary block are usually hypermetro. Non-pupillary block mechanism can occasionally occur in myopic eye. Up to one in six patients with hypermetropia, one diopter or more, are primary angle closure suspect. So routine gonioscopy should be considered in all adults who are hypermetropic. Axial length short eyes tend to have a shallow AC secondary to the relatively anteriorly lens position. Eye with nanophthalmos axial length less than 20 millimeter have a short eyes and are at particular length. So basically, those having a that a short eyes usually have a hypermetropia. So short eyes having a short axial length will have a hypermetropia, and short eyes are have a hypermetropia, and they both have um, risk factors for developing mm, angle closure glaucoma. So, how will you diagnose a patient of angle closure glaucoma? Symptoms precipitating factors including watching television in a darkened room, pharmacological mydriasis or rarely miosis, adoption of a semi-prone position, for example, reading, acute emotional stress, and occasionally systemic medication, parasympathetic antagonist or sympathetic agonist, including inhalers, motion sickness patches, and cold flu remedies, mediatic effects, topiramide, and other sulfa um, derivatives, ciliary body effusion. So these all are causing basically what is basically causing mydriasis. So whenever there is a dilatation of the pupil, the iris will roll on the angles, and the already narrow angle will become occludable, and it will cause the symptoms in these cases. Presentation can be with intermittent symptoms of blurring, smoke filled room, and halos, rainbow around lights. Due to corneal epithelial edema or acutely with markedly decreased vision, redness, and ocular or periocular pain and headache. So, headache can be important factor. There will be sometimes decreased vision. There can be the smoke filled room, and these are basically halos are basically the symptoms of a corneal epithelial edema. Abdominal pain and other gastrointestinal symptoms may occur. Most patients with angle closures are asymptomatic, including most of those with intermittently or chronically elevated IOP. So, very important are what are the signs of the angle closure glaucoma. So, there can be acute, early presented patient with glaucoma, and there can be chronically present. So, if the patient acutely present with acute primary angle closure, previously called acute glaucoma, has a visual acuity because he is in the emergency, he will present in an emergency, he will have a certain decrease in vision. Visual acuity is usually 6 by 60 to hand movement, very low vision, and the IOP is usually very high, 50 to 80 millimeter mercury. There will be the conjunctival hyperemia with violation circumcorneal injection. There will be the corneal epithelial edema, AC is shallow, and aqueous flare is usually present. A non-reactive mid-dilated vertically oval pupil is classic. So there will be the non-reactive, so the pupil will not be reacting, and there will be the mid-dilated vertically oval pupil in this case. The fellow eye typically shows an occludable level. If this is not present, secondary causes of angle closure should be considered. So in acute presentation, everything is bad. Vision acuity, there will be the aqueous flare, there will be the corneal edema, I will be through the skies, and you can see the other eye have an occludable angles. So if somehow that a patient present to you with the resolved acute primary angle closure glaucoma, how will it present? If it present early, low IOP, ciliary body shutdown, and effect of the intensive treatments, there will be the folds of the Dasman membrane. If IOP has reduced rapidly, an optic nerve head congestion and choroidal fold. So in this case, in the very high IOP, there will be the acutely raised IOP, there will be the optic nerve congestion and the choroidal folds as well. And because the IOP has been reduced significantly, there will be the folds in Dasman membrane, and there can be even a low IOP. If it present late, there will be the iris atrophy. So how will you, if a patient presents to you and you do not know that patient has some angle closure, you can still see is have you can diagnose that patient sometimes in his or her lifetime have an angle closure, acute angle closure attack. You will know it by there is a spiral shape configuration. There will be the lens infarct, whitish shape, and that is how you will uh, know that a patient had an attack of angle closure in previous lifetime. Iris atrophy with spiral like configuration glaucoma fleckens is a white foci of necrosis in the superficial lens and other forms of cataract and irregular pupil due to iris sphincter or dilated damage in posterior synchrony. The optic nerve may be normal or exhibiting various signs of damage including pallor or cupping. The greater the duration of an attack of APAC and the extent of the post APAC pass, the lower likelihood of the IOP control with medication unknown. So, how much duration the AP has lasted will depend, and how much pass has been formed will depend on how it will get medical treatment. So, whenever there is a significant pass, the medical treatment will not be sufficient. You have to go for the surgical therapy as well. So you can see this figure, this is 11.37. It is showing the resolved acute primary angle closure. A is showing folds in the descendant membrane in a post congestive angle closure. B is showing glaucoma fleckens, which is basically the focal necrosis on the lens, and it is showing the spiral shape atrophy. And D is showing D is showing us the optic atrophy combined with pallor and cupping. So next is a subacute angle closure. The subacute angle closure is used to describe the clinical scenario of intermittent episodes of spontaneously resolving mild or moderate APEC, usually in patient with a pupillary block. The clinical course may be chronic or may culminate in a more severe or unresolving episode of APEC. So basically, in patient may sometimes have an intermittent episodes of the mild to moderate angle closure. So it is called the subacute angle closure. If a chronic presentation, visual acuity is normal unless damage is advanced. The AC is usually shallower in relative pupil block than in non-pupillary block. IOP elevation may only be intermittent. Creeping angle closure is characterized by the gradual band-like anterior advance of the apparent insertion of the iris. It starts in the deepest part of the angle superiorly and spreads circumferentially. Intermittent ITC may be associated with the formation of the discrete pass, and visual lesions have pyramidal sawtooth appearance. Optic nerve signs depend on the severity of the damage. So the chronically present patient may have occludable angles, and you will see that they have sometimes have a IOP elevation, sometimes they do not. They will have a angle closure on the gonioscopy. So we can see figure 13.33b that has already been passed. So how will you investigate a case of an angle closure? You can do anterior segment OCT. Anterior segment OCT, ultrasound biomicroscopy, or skinflint photography may be useful to supplement gonioscopic findings and for the patient education. You can do anterior chamber depth measurement is helpful in some cases, so you can know that it is a narrow angle, narrow AC or a shallow AC or a deep AC. Biometry if lens extraction is considered. Posterior segment ultrasonography is in atypical cases to exclude causes of secondary angle closure. Provocative testing. This may aid decision making in some circumstances, particularly when the plantar iris syndrome is suspected. Pharmacological mydriasis is a poor discriminator and carries a small risk of precipitating APEC in susceptible patient without a patent iridotomy. So the dark room or prone provocative test. The patient sits in the dark room, face downward for 1 hour without sleeping. Sleep-induced miosis. The IOP is checked before and immediately after the test, as IOP can normalize very rapidly. An IOP rise of 8 mm mercury or more is considered significant. Gonioscopy without indentation should be used to confirm closure of the angle. If the test is positive in a patient with a laser iridotomy, the underlying anatomical cause is a plato iris, which can be confirmed with an OCT scan. A positive response is abolished after lens extraction. So it is basically showing us a test, basically which is used to determine about the plato iris. And will give us the idea about the angle closure. So what is the patient is asked to sit in the dark room. So the dark room and will face down. So what will it do is basically it is inducing mydriasis. As it is inducing mydriasis, there will be the occlusion of the angle, and the IOP is raised. So IOP is checked before and after the test, and if it is more than 8 millimeter mercury, it is considered that it is positive. And if this test is positive in a case of having already patient going on a laser peripheral iridotomy, plateau iris is being diagnosed. Differential diagnosis of acute IOP elevation. So what are the DDs of you have a patient present with the narrow angle? There will be the lens induced angle closure due to swollen or subluxated lens, malignant glaucoma, aqueous misdirection, especially if the patient has recently undergone intraocular surgery. So basically in a malignant glaucoma, this is a ciliary body which is producing the aqueous humor. In a case of the malignant glaucoma, basically instead of going into the posterior chamber, the aqueous start going into the vitreous, which causing the increase in IOP because there is no outflow from the vitreous. Other causes of a secondary angle closure with or without pupillary block. Neovascular glaucoma may occasionally cause the sudden onset of pain and congestion. So neovascular glaucoma can be open angle and angle closure as well. Hypertensive uveitis, for example, iridocyclitis with trabeculitis, particularly hepatic, including cytomegalovirus, glaucoma, cyclitic crisis, Posner-Schlossman syndrome, scleritis with or without angle closure, pigment dispersion, pseudoexfoliation. So these are all can cause the angle closure. Orbital or retroorbital lesion, including orbital inflammation, retrobulbar hemorrhage, and the carotid cavernous fistula. So how will you treat a patient of a angle closure glaucoma? So if a patient present to you with acute primary angle closure, how will you treat it? So initial treatment, the patient should lie down in the supine position to encourage the lens to shift posteriorly under the influence to gravity. So you ask the patient to lie down. Acetazolamide 500 milligram is given intravenously if the IOP is greater than 50 millimeter mercury, and orally if IOP is less than 50 millimeter mercury. So basically acetazolamide is um, carbonic so basically it is a carbonic anhydrase inhibitor. It will decrease the IOP. Contraindication includes sulfonamide energy and angle closure secondary to topiramide or other sulfonamide derivatives. So we do not give acetazolamide in the sulfonamide allergy. A single dose of apraclonidine 0.5%. So apraclonidine is basically uh, 0.5% or 1% timolol 0.5%, which is a beta blocker, and prednisolone 1% or dexamethasone 0.1% is instilled into affected eye, leaving 3 to 5 minutes between each. So you instill all these drops, which is alpha 2 agonist, apraclonidine, beta blocker, and steroid, and between each drop we give the time of 3 to 5 minutes. Pilocarpine 2% 1 drop to the affected eye, repeated after half an hour, and 1 drop of 1% into the fellow eye. This should not be repeated if the IOP remain greater than 40 millimeter mercury, as the ischemia may compromise its action, may exert a forward vector, and excessive dosing carries a systemic toxicity. So basically pilocarpine is given to induce meiosis, and how much is it is given is basically 2% 1 drop into affected eye, and after 1 hour we repeat it, and if the IOP remains greater than 40 millimeter, we do not give it. Analgesia and antiemetics are required because sudden increase in intraocular pressure can cause the patient nauseatic. So if a resistance case is central corneal indication with a squint hook or indentation golion lens to force the aqueous into the angle. Epithelial edema can be cleared first with a topical 50% glycerol to improve visualization and to avoid abrasion. Mannitol 20% 1 to 2 gram per kg intravenously over 1 or oral glycerol 50% 1 gram per kg, or oral isosorbide 1 to 1.5 gram per kg. Having checked for contraindication, early laser iridotomy or iridoplasty after clearing corneal edema with glycerol. Paracentesis is affected but carries a small risk of angle lens damage. So what you can do in case the if it is not treated with initially, you start giving them mannitol. uh, you can massage the eye with the corneal indentation, and you force the aqueous to go to the angles, and you can clear the before it you can clear it with the topical 50% glycerol to improve visualization. You can give mannitol 20%, or you can give glycerol orally or oral sorbide and after the check for contraindication. When you clear all the corneal edema, after corneal edema, you can do early laser peripheral iridotomy or iridoplasty to open the occludable angles. Paracentesis is affected, you mean you just do AC tap and or vitreous tap so that IOP is reduced, but it have a risk of lens damage. Surgical options include peripheral iridectomy, lens extraction, conioneclysis, trabeculectomy, and cyclodiode laser treatment. So, subsequently, we can do all these things as well. So, subsequent medical treatment, pilocarpine 2% 4 times daily to the affected eye and 1% 4 times daily to the fellow eye. So, pilocarpine is basically given to induce meiosis and to prevent the occlusion of the angle. Topical steroid prednisolone 1% or dexamethasone 4 times daily if eye is acutely inflamed. So we give steroid in this case because there is a lot of inflammation going on in ankle closure glaucoma. Any or of the following should be continued according to response: timolol 0.5% twice daily, apraclonidine 1% 3 times daily, and oral acetazolamide 250 milligram 4 times daily. All three regimes are basically given: beta blocker, alpha 2 agonist, and carbonic anhydrase inhibitor. Bilateral laser iridotomy is performed once an attack has been broken, signified by a clear cornea and peripherally normal IOP. Topical steroids are continued for at least a week. So once the attack is resolved, you can do bilateral laser iridotomy. Gonioscopy needs to be repeated to ensure the angles are open. Subsequent management is as for post iridotomy chronic primary angle closure glaucoma or low threshold may be adopted for cataract surgery, particularly if a significant phacomorphic element is suspected. Trabeculectomy is occasionally necessary for the persistent IOP elevation despite a successfully open angle. So basically, if all these management fail, you can always go for the surgery, and you can do cataract extraction as soon as possible if there is an cataract formation, because the cataract extraction lower IOP by 15%. Now, how will you treat a case of a primary angle closure suspect? Laser iridotomy. So, ZAP trial we have discussed already. The ZAP trial conclude that laser PI has a modest prophylactic effect, but should only be offered to those with a high risk of developing primary angle closure glaucoma. If significant ITC persists after iridotomy, options include observation, laser iridoplasty, and a long-term pilocarpine prophylaxis 1% twice daily. If symptomatic cataract is present, lens extraction usually opens the angle. If IOP is elevated, then by definition, primary angle closure is present. So basically, you can do a laser iridotomy in the case, and you can do observation, and you can do some prophylactic measure. You can do iridoplasty, you can give pilocarpine to the patient, and if there is a cataract, you can remove the cataract. So how will you treat the primary angle closure and primary angle closure glaucoma? Management is the same as that recommended for the primary angle closure suspect, but with lower threshold for further intervention if angle widening is inadequate after iridotomy, particularly if IOP remains elevated. Urgency and intensity of the treatment and frequency of the review is tailored to the individual patient in considering IOP, extent of the angle closure, and glaucomatous damage if present. So review depends upon how the patient present to you. Medical treatment is as for POC may be required for eyes with substantial cynical closure or with persistently elevated IOP despite an open angle. Trabeculectomy with mitomycin is an option but may result in malignant glaucoma. Phacoemulsification with the intraocular lens implantation is highly effective as it corrects hypermetropia, deepens the anterior chamber, and opens the filtration angle. IOP is achieved in almost all the patients whose IOP is within normal range prior to surgery, and in up to 80% of those with IOP is higher than normal preoperatively. The EAGLE study effectiveness of early lens extraction for the treatment of a primary angle closure glaucoma concludes that the clear lens extraction with IOP IOL implantation show a greater efficacy and is more cost effective than peripheral laser peripheral iridotomy in patient with primary angle closure and IOP greater than 29 millimeter mercury and or in patient with primary angle closure glaucoma. So basically there is an EAGLE study. EAGLE study, lens extraction reduces IOP. So if a patient is having a primary angle closure or primary angle closure glaucoma, so if you do the clear lens extraction, the most of the time it reduces IOP, and it is more effective and cost effective than laser peripheral iridotomy, especially in a patient who's a primary angle closure and having IOP greater than 29 millimeter and with the primary angle closure glaucoma. So that's it for the glaucoma part 7. See you in the next lecture.